अच्छा दिखता है। Who chose, allow me the screen sharing now. Can you guys hear us? Can you guys hear us? Guys, I think we'll be starting in a few minutes. I think this is probably a very, very niche topic, and I think we'll have some case study discussion and some treatment. And this is a follow-up from the last class we did 4 weeks ago. And I think I'll do a quick review of the symptoms and what all can be affected by C1 dysfunction, and then followed by some manual treatment. It is a very, very tricky topic, and a lot of new research is coming out, but I think we still have a lot of unknowns. So we'll spend some time understanding it, and I promise that you are all seeing these patients in the clinic and probably missing it or ignoring it because the information on this is a little bit misleading. So I have some case studies, and that will actually help us understand how the patients can present. And these patients really struggle because some of the symptoms are very, very misleading. And I think we'll spend some time talking about parts and talking about wide variety of symptoms that can be associated with C1 misalignment. Okay. I think we'll probably start in 5 minutes. I think I don't see a whole lot of people joining in, so I think we'll wait till 6:35 my time. Okay, and 5:05 your time. And I think we'll start around 5:05. I have a subject coming at 7:30. 7:35. Okay. And I think I'll demonstrate some of the techniques we can use. I think it's important to understand how things can move and how things can be in dysfunction. We'll do a little bit of a review on biomechanics, understanding how C1 can move. And to be honest, it's a very, very tricky topic, and a lot of people don't know how to treat it. I would say like 99% people don't know how to treat it. So it's important to understand how things can be misaligned. If you have attended our courses in the past, we do to talk about C0, C1 in a lot of details, but I think we're just adding another layer of complexity to it. We do treat C0, C1. If you've gone through our program, we talk about C0, C1 in a lot of details, how to screen it. But this is just an additional layer of complexity, because even in our course, which is probably the most advanced course available, or one of the most advanced course available, we don't talk enough about autonomic dysfunction. Okay. We talk about cervicogenic headaches. We talk about cervicogenic dizziness. We talk about wide array of symptoms. We talk about Horner syndrome in our program, but we don't talk enough about something called as dysautonomia. So this, I mean, and dysautonomia or has an overlap with something called as POTS, which is also called as postural orthostatic tachycardia syndrome. So there's a little bit of overlap between dysautonomia and POTS. And I think in our course, we don't talk about enough. Maybe in future courses, we'll probably talk about it. We run this 1-year program where you can take a class every 1 weekend a month, and then you can go through the program. We have developed these 12 modules, which are self-paced and very, very advanced stuff. From your basic PT, you can take each module and learn wide variety of things. I think they are recorded lectures. You can listen to them. And once you go through the program, then you can attend our hands-on. Okay. So that you have like kind of foundational understanding from where we are coming from. And okay, I think without wasting much time, I think we're going to talk a little bit about C1 biomechanics. If you didn't attend the last class, the previous part 1 is on YouTube. I think you can find it on Gem Physio YouTube channel, and you can listen to it. So this is a continuation of what we did almost a month ago. And I'll try to make a sense of it, because even online, there's not a lot of information available on it. A lot of people, I feel like, try to treat it. I do think that chiropractors who are trained in treating Atlas are the best people to treat it, or they know how to treat it. So a lot of information comes out from their scope of practice. But I do think that they don't understand the level of complexity, because they just treat C1. They don't treat the pelvis, they don't treat the thoracic spine, they don't treat other parts of the body. So some of the case studies will make sense. I'm seeing plenty of patients who have C1 dysfunction or POTS syndrome in the clinic. So some of the case studies come from that. If you're practicing in India or other parts of the world, I promise that you're seeing them. You're just not paying attention to what they're telling you. Or sometimes you're just straight away referring them, and they're going from clinic to clinic without finding a solution to their problem. And because MRIs, CTs, and other types of imaging wouldn't show anything. Okay. This is a very, very niche topic, requires a good eye or a very strong clinical eye to pick this, because I think I'm telling you, a lot of people are missing this. Okay. Without wasting too much time, I'm going to go back to the biomechanics, and we're going to talk about biomechanics. And this is from the previous lecture we did. This is my C1, right? And I'll try to make sense of it. If you have difficulty understanding it, you can ask me questions. Okay, so this is C1, and C1, especially when it's hypermobile, it can have 6 degrees of freedom, which means that it can move in 6 directions. Okay, so it can flex. Okay, it can extend. Okay, I would say that extension is more common because of the forward head posture, right? So this is backward rotation of the whole body. It doesn't have a body, the backward rotation of whole thing. That is extension, right? Okay, so it can flex, it can extend. Okay. Give me 1 second. I just want to move this out of my way. Okay. One of the common things we see, it can also do something called as lateral bending. When we were talking about palpation last time, the only structure you can palpate, pretty much palpate on C1 is the transverse process. How to palpate transverse process of C1? You find the mastoid process, you come anterior, inferior, and the first lateral mass you're going to hit is your transverse process of C1. You cannot miss it. So if you want to palpate the C1 transverse process again, because it will all make sense what I'm talking about. So, and you can see whether one is lower than the other. There may be side-to-side differences, but if the side-to-side differences are huge, it can cause, so you can have a little bit of something like this, where one side is higher, one side is lower, something like this, right? Okay. So, so you have flexion. Flexion is this, extension is this, then you have side bending. Okay. It can also rotate like this. Okay. It can also glide anteriorly. Okay. Or it can glide posteriorly. One thing, just understanding the forward head posture, we know that out of the ones we've discussed, the most common one could be, it could extend, which means this, and it can also go anterior glide. That is very common. But the problem with this situation is that you can have combination of any of these, which I will talk about in the case studies. So it's important to understand. Then there is something called as lateral glide, which means that there is a lateral shearing. So you're just basically getting the lateral glide. And we have something called as compression and distraction, which means it's just moving up and down. Going back to the last lecture, we spoke about this is more common in patients who have Ehlers-Danlos, patients who have multiple whiplashes, history of hypermobility, or patient who falls into a category of hypermobility syndrome, right? So just a quick review again. I'm going to move it flexion, extension, lateral bending, rotation could be either side. You have an anterior glide, you have a posterior glide, you have a lateral glide, and then you have axial compression and distraction. And that's why the complexity is much higher, because you can have combination of different things. And you have to be very skilled to appreciate that. A lot of people who practice Atlas orthogonal chiropractic care, they assess it on an X-ray. They do an open mouth X-ray. They try to look at the transverse process from a sagittal view, from a frontal view, and from a transverse view. And then they can tell, oh, it's side flex 5 millimeters, rotated 5 millimeters. And with the naked eye, sometimes it can become very challenging. But as a skilled manual therapist, that's where the skill comes from, because you should be able to pick stuff which most people are missing. And I do think that if you understand the biomechanics, I can tell how it is shifted by just feeling for the transverse process relative to other structures around it, relative to other structures, relative to C0, relative to occiput, relative to C2. Yeah. Because C1 is very easy to palpate transverse process. Yeah, you can't miss it, right? Depending on patient symptoms, you can tell whether it's side flex, rotated, anterior translated, posterior translated by just feeling it. Okay. And comparing it to the structure surrounding it. Okay. Okay. Moving on to, I think I explained this pretty good. Flexion extension. This is the nodding movement. Okay. And then lateral flexion is this. Okay. Okay. Axial rotation is this. Okay. You're just doing a rotation. Anterior and posterior glide was like linear going forward, backward. Lateral glide was just lateral translation. Okay. You can look at the symptoms that it can cause. Usually you'll find like a combination of symptoms. Okay. When we're going to talk about POTS, so you'll understand what I'm talking about. Okay. Compression and distraction, which was this, can cause a lot of pressure around the eye, can affect the CSF. I'm going to explain a patient story so that you understand how understanding this problem can actually help patients. I'm seeing somebody, she has Chiari malformation, and I'm very careful about how I adjust. I don't do a lot of adjustments because she has underlying hypermobility. She's 18. She always feels like there's a lot of pressure on the eye because of restriction in CSF blood flow, right? And even doing a little bit of distraction, she feels like she can open her eyes more. Okay. And that's where manual therapy can be very, very powerful, especially if you know how to treat C1 and you're treating patients who have history of, or patient who have diagnosis of POTS. Okay. Okay. Moving on to talking about symptoms associated with C1 misalignment. So you can have wide variety of symptoms. I think last class we were discussing how you can have neurological symptoms. I think this is very, very common. We see headaches all the time, right? Cervicogenic headaches are common. They could be also related to C1 misalignment. It's the same thing. It could be because of compression on the trigeminal nucleus or overfiring of trigeminal nucleus. It could be because of, the more common one is your GON, greater occipital nerve. You can also have visual disturbances like blurred vision, can have fullness in the ear. One of the case studies, I think patient had like TMJ dysfunction with it, which I'll talk about. Okay. You can have difficulty in swallowing. I'm seeing another patient who's not a part of the case study. Some of the symptoms she present is voice fatigue and difficulty in swallowing. Okay. Because misalignment of this can put a lot of pressure on the throat. Okay. And that can cause dysarthria, difficulty in difficulty in talking and difficulty in swallowing. Okay. Okay. Another, and this is an overlap with POTS, which we're going to talk about. We've seen that even in the last class, we were talking about how C1 misalignment can affect something called as vagal enteric system, which means that your vagus nerve supplies your gut, and you can have symptoms of indigestion, nausea, vomiting, if this is misaligned. Okay. You can also have orthostatic intolerance. This is all coming from vagal related problems. Okay. You can have confusion, brain fog, poor concentration. Okay. Restless sleep, insomnia. Okay. So if you're seeing patients who have C1 misalignment, neck pain, and they're falling into this category where they have abnormal heart rate, digestion, they feel dizzy all the time. Whenever they stand up, they feel like they're dizzy. They are not able to, they feel confused. They have difficulty concentrating. They're not able to sleep. They definitely fall into the category of vagal dysfunction. Okay. Secondary to C1 misalignment. Okay. Okay. Other things that are more common we see all the time are the musculoskeletal. You see pain and stiffness. You see range of motion deficits. Can have thoracic outlet with it. Okay, those are like more common symptoms, more simple symptoms to treat. And vagal symptoms are missed. Autonomic system symptoms are missed. Neurological symptoms are missed. Yeah. Okay. Then you can also have symptoms related to the vertebral artery. And the confusion comes in when you have combination of symptoms. When patients start talking about few symptoms from autonomic, few symptoms from vascular, few symptoms from neurological, few symptoms from musculoskeletal, then this makes the picture very, very complex. Okay. Because and throws off a lot of providers because they don't know what to do and how to treat, why this patient has neurological, autonomic, vascular, musculoskeletal symptoms. Okay. And they are part of the same puzzle. Okay. You have to understand the biomechanics of this. Okay. Yeah. Some overlap symptoms patients may have. We know that cervicogenic cervical problems can cause dizziness, but dizziness is also a part of something called as POTS. After this, I think I'm going to talk about POTS so that you understand what POTS is. Okay. You can have a vestibulo-ocular reflex dysfunction. We know that your upper cervical supplies the back of the cerebellum, right? Through those pyramidal tract, extrapyramidal tracts. Okay. So you can also have a vestibulo-ocular reflex dysfunction associated with it. Headaches are common. Yeah. Okay. Let's spend a little bit of time talking about POTS because this is fairly common if you have C1 misalignment, and let's break it down on what POTS is. Okay. So if you look at it, it's like postural orthostatic tachycardia syndrome. Postural means we know it's related to position. Okay. I think there's a question, lateral flexion, lateral side bending, both are the same movements? No. One is a physiological movement and one is a arthrokinematic movement. This is a, okay. So this is lateral bending and this is lateral glide. So one is a physiological movement, one is a arthrokinematic movement. They're not the same movement. Okay. So talking about parts, so you have postural, right? Postural means position related. Okay. Some patients would have symptoms with sitting. Some patients would have symptoms when they just stand up. Most of these patients have symptoms when they just stand up. Orthostatic means upright, right? So these patients have position related symptoms when they're standing upright. Tachycardia is increase in heart rate. So these patients would have heart rate greater than 100. Okay. And then syndrome is complexity of symptoms. Okay. So these patients are presenting with position-related symptoms that are related to upright posture, causing cardiovascular problems. Okay. And I think it is, again, going back to vagal dysregulation. Okay. It's related to vagus nerve. You're getting a vagal compression. And vagus nerve supplies wide variety of systems. So you're getting this complex presentation. Okay. Cardiovascular symptoms could include rapid heartbeat, palpitations. I was looking at Cleveland Clinic's website. According to them, the most important symptom is patient would feel dizzy all the time. Patient would say, I have this resting dizziness. I feel dizzy all the time. I feel more dizzy when I'm upright, but even when I'm laying down, I feel dizzy. There's this resting dizziness that stays with me regardless of what I do. And that is a classical presentation of postural orthostatic tachycardia syndrome. When they become upright, their heart starts beating, blood pressure, BP, heart rate greater than 100. Okay. And they feel like unstable. They have difficulty concentrating. They have something called as brain fog. Okay. Sometimes they can have tremors, visual disturbances, fainting episode. The patient I was talking about who's 18, which is one of our case studies, she gets like this one fainting episode every month where she just faints because of POTS. Okay. Yeah. A lot of fatigue. They have difficulty, poor exercise tolerance. They can't exercise. Whenever they exercise, they feel like they're gonna pass out or feel like dizzy. Okay. And they have other symptoms. They have if you have these many symptoms, you're going to be anxious. You're going to have some difficulty with sleep. And I think also GI symptoms, as I was talking about it, they feel indigestion with whatever they eat. So that's another way to actually differentially diagnose. If you're asking them what brings on their indigestion, it doesn't matter what they eat, they feel indigestion. So it's not diet related. If you feel indigestion with anything you eat, then it's not food allergy, or it's not lactose intolerance, or it's not gluten intolerance. It's just that their GI system is overloaded because of the affected vagal inputs. Okay. So a lot of GI issues. So this is a difficult diagnosis to understand, because a lot of providers, even like a lot of endocrinologists, a lot of gastroenterologists, they have hard time relating this to a C1 dysfunction. Okay. But we know for the fact that this could be a part of the puzzle. Sometimes not the complete puzzle, but could be a part of the puzzle. So if you're seeing patients with neck pain, patients who have cervicogenic dizziness, who shows cardiovascular, GI, autonomic symptoms, make sure that you look for POTS. Do they present with a lot of dizziness related to standing? Yes, you can have symptoms related to in IBS too, but I mean, IBS patient would not present with dizziness, would not present with cervicogenic dizziness, or would not present with exercise intolerance, right? That's IBS would just present with GI symptoms, right? Would not present with other spectrum, not present with neurological symptoms related to vagal irritation, related to brainstem irritation. Okay. So this is a very, very niche topic, and kind of a difficult diagnosis to understand. And that's why I think this will be loaded on YouTube. You can watch part 1, part 2, and do your own research. I think this is an interesting topic because very few people understand how to treat this one. Because I think I see these patients and they go to wide variety of providers and they don't have a clue what's going on. Okay. So, and your understanding of C1 biomechanics, how it can move. And as therapists, as manual therapists, I think we have a very good understanding of how to palpate, right? How to align things, and that can make a hell lot of difference in patient's life if you know what you're doing. Yeah. Yeah. I'm gonna throw like few case studies, and I'm gonna talk about case study 1. Okay. So I'm seeing this 33-year-old and these are real patients, so these are not from internet. I'm seeing them, and I can tell you that they are real patients and they have presentation which is out of ordinary. Most of them have seen more than 10 to 20 providers. So this is my patient is 33-year-old. She been experiencing symptoms since 2015. The symptoms, she was fine. The symptoms started after she attended some self-defense class. And if you understand that self-defense classes, they do like a lot of holds around the neck, right? So some form of mechanical trauma happened. Okay. During that class, there's just one class she attended. And then she started experiencing neck pain, low back pain, headaches, dizziness, gut issues, bilateral arm and leg numbness. All the symptoms I'm talking about, the origin of these symptoms are not at the same time. So the onset did not happen. The onset happened in layers. So it started with headaches, then dizziness, and then over the period of time, she's developed gut issues. She's developed bilateral arm and leg numbness, and some of the POTS symptoms, I think, which I was talking about. Okay. So she sees this Atlas orthogonal chiropractic physician. Her name is Dr. Brisley. She practices in Austin. She's one of the 300 people in the nation who treats this stuff. And but when the symptoms have been going on for a long time, you start developing secondary dysfunctions. If it starts at C1, then you start developing problems in the upper back, you start developing problems in the pelvis, because your body just tries to fight that misalignment, and you start developing dysfunctions elsewhere, right? So I started seeing her probably a month ago, and these are the findings. She has a lot of low back pain. I'm primarily addressing low back pain. I did assess her neck. I treated some of the neck portions, but she's also seeing the chiropractic physician who referred the patient to me. She has some 7 to 10 pain at rest, and during activity, it becomes worse. She cannot bend forward. So we know there's something going on with the pelvis. I think we have a SI course we talk about where we try to treat complex pelvis issues. So I'm going to talk about that too, but I think let's try to understand the C1 stuff. Okay. So I'm going to primarily focus on C1, what I found, because you can see the pelvis findings. She has an upslip, inflare, outflare on either side. She has sacral flexion and extension. And I think it's very easy to treat that if you know how to understand pelvis, but that's not what I'm going to focus on. I'm going to focus on what presentation I found, because this lecture is on C1. So we're going to talk about that. So, and especially patients who have hypermobility, their presentation could be different on different days. They might present with one dysfunction on the day of evaluation, and on the second follow-up, they can present with totally different. And the game is to align it and then stabilize it and treat secondary dysfunction. If they have a dysfunction in C1, you treat C1, and they have dysfunction in pelvis, you treat pelvis. Okay. So this is how she presented according to me. Okay. I was checking the right side. I felt like it was side flex and rotated like this. Okay. So the transverse process was anterior and inferior. Okay. And there was a little bit of anterior translation, which happens to most patients because everybody likes to sit like this, right? So this was the presentation that was causing all wide variety of symptoms: back pain, neck pain, numbness in the arms, numbness in the legs, gut issues. She feels dizzy all the times when she stands up. Okay. There's a resting dizziness that stays with her, but when she stands up, she feels like extremely dizzy. I think I asked her how, on a scale of 0 to 10, how would she rate your dizziness? She said 7 or 8. Okay. And then there is a 3 or 4 dizziness that stays with her all the time. Okay. So right anterior, inferior, this was the presentation. I'm just focusing on C1. Okay. And so that when you're palpating them in the clinic, you can appreciate whether the one side is down, one side is forward, so you can understand whether it's rotated forward or it's side flex, or you see an anterior translation or you see a posterior translation. Okay. So this was our case study 1. Okay. Let's call case study 1 right anterior inferior transverse process anterior translation. Okay. Because when we're going to talk about treatment, we'll talk about how you can address this. Okay. Case study 2, and this is actually a very interesting patient, Indian American patient, 18-year-old, always feels dizzy, resting dizziness always stays with her. A lot of tachycardia related symptoms. She's seen a cardiologist, she's seen a gastroenterologist, she's seen an endocrinologist, wide variety of physicians, changed diet, changed nutrition because of gut issues. At one point, she was diagnosed with IBS. She's tried everything. When we were doing like history taking, I asked if any foods bring her symptoms. So she says, it doesn't matter what I eat, I have indigestion, which tells you that it's not related to diet. When the C1 you should be able to palpate C1 on everybody. That's like, yeah, should be able to palpate C1. I think C1 is not a hard structure to palpate, especially the transverse process. I mean, it doesn't matter who you're palpating on. C1 is very easily palpable. But I think the idea is to get in the habit of palpating it. Whenever you see presentation like this, or even if in any neck patient, I would check C1 transverse process. Get in the habit of palpating C1 transverse process. And I think we'll develop that knack of understanding whether it's side flex, rotated. If they don't have a whole lot of symptoms, it's fine. But if they're presenting symptoms, you'll be able to make a correlation. And sometimes patients won't tell you their gut problems, right? Because that's not why they're seeing you for. They usually see you for pain or headaches or dizziness, right? So this patient also has Chiari malformation, and she's 18. She had a growth spurt when she was 13, 14. She's fairly tall. So growth spurt started like between 13 to 15, and she started developing wide variety of symptoms of dysautonomy or POTS. Okay. When I tested her, she was feeling dizzy, a lot of cardio and GI nausea related symptoms in last 4 to 6 weeks. History of Chiari related syndrome. And I think she was diagnosed with Chiari when she was very young, but then she had another MRI 4 to 5 months ago where they said that, yes, you have Chiari, but MRIs look okay. You don't need a surgery, just do rehab. And that's why she was seeing us. Okay. So pain and stiffness in the low back and cervical spine, restricted cervical movements. Okay. You can look at the range of motion, other findings. If you have attended our classes, we talk about MIA dysfunction on C0, C1. We talk about lips dysfunction. She had a left C0, C1 dysfunction, MIA dysfunction, which means that your occiput is sitting medial, inferior, anterior. We're not going to talk about this in detail. We're going to talk about C1, so we're more interested in. So she had very similar presentation, anterior, inferior, and anterior translation of C1. The funny thing was, I saw her first visit, her findings were this. I saw her second visit, her finding was this, exactly opposite. Okay. And the good thing about hypermobile patients who have history of Chiari or people who fall into hypermobility, it's not hard to correct it. And you would see like improvement right away. If you correct it, manual doesn't have to be aggressive. Even a grade 1 manual, you can easily align C1, okay? As long as you understand it. Understanding is the key. And with hypermobile patients, the force is very low. I could just put like 2 newtons of force and I feel a click and I see and then I check the C1 and I say, it's fine. She stands up and walks. I'm fine. I'm feeling great right now. I don't feel dizzy anymore. So that gives you an assurance that you're not making up stuff. You're treating the right thing. If you can dramatically improve patient symptoms by just doing one manual technique, by correcting C1, and you can feel that it doesn't look lateral bent or forward rotated on one side or anteriorly translated, you know that you're doing something right. And your patient says, her response after the first appointment was, I feel like I can look wider in my eyes. I feel less pressure on my eyes. I don't feel dizzy anymore. Just one gentle C1 alignment technique, which I think we're going to talk about. Anybody can align it. It's very simple. Okay. C1 is such a palpable structure. If you know the direction of force, you don't even have to put a lot of force if the patient is hypermobile. Just a gentle grade 1 technique, and you can improve patient symptoms. The bigger challenge is training the muscles, doing a lot of vestibulo-ocular exercises, gaze stabilization exercises, so that they can maintain that. That is where the bigger challenge is. Okay. But key thing is you understand how things are moving. I sometimes do METs when I feel like I can't. If patients are not hypermobile, patients are very, very stiff, okay, and they have chronic issue, I do a lot of METs to correct or try to correct this, okay. Okay. So this was case study 2. Very similar, but I'm going to talk about case study 3. I just started seeing her. I think I've seen her like one time. And I'm just putting this case study because she presents with case study very similar to case study 1. She does fall in a hypermobile category. Symptoms of Ehlers-Danlos, okay? A lot of upper back pain, scapular pain, symptoms in the hand, a lot of leg pain. She feels like her legs are heavy, okay? Bilateral foot pain, a lot of symptoms of POTS. Though her symptoms of POTS were very mild, she has like mild gut irritation. And the funny thing about all these patients are, most of these patients have never been diagnosed because they go from provider to provider, and everybody tells them a different thing, and they start there's a trend in US. People have started putting their symptoms on Chat GPT, and they're finding their diagnosis. It's pretty wild. that people are finding diagnosis on Chat GPT and they're not going to the providers, and providers are missing this. Because if you go to a provider just looks at your gut. They cannot make that association where gut is related to the neurological symptoms, are related to the autonomic symptoms, are related to the pain, musculoskeletal symptoms, because it's a kind of a cluster, right? So she does fall into the category of hypermobility, but we don't have the genetic diagnosis. We don't know whether it's EDS. She looks like EDS because if you check the Baton scale of hypermobility, which we talk in our module 1, she presents like 10 on 10. Every hyperextension in the elbows, hyperextension in the knee, full spine flexion, she falls into the category of Baton hypermobility syndrome. Okay. She has a history of car accident, history of left knee surgery, upper back pain, pain radiation to the arms and legs, bilateral foot pain. Okay. I'm still focused on what I'm finding with C1. Okay. And you can see intensity is 4 on 10. Okay. 7 on 10 with activity. I think let's focus on what we're more concerned about. Another anterior translation C1. Why I'm seeing a lot of because most of these patients are right dominant. And my next case study, my patient is left dominant, so I think he presents exactly opposite. Okay. And we name the dysfunction based on the symptomatic side. So this patient is also right inferior C1 anterior translation. Another crazy thing is she also had a pelvic dysfunction and C0, C1 dysfunction. So after correcting everything, a dramatic improvement in symptoms. Hypermobile patients would show you, if you know what you're doing, if you correct them, they would show dramatic improvement in dizziness just in 5 minutes if you know what you're treating. Okay. She felt like she was more centered. She felt that she doesn't present with that dizziness she came in with, because I think C1 is a huge component of all these wide variety of syndromes. Okay. Yeah. I think my subject comes in around 7:30. I think I'm going to show you some of the techniques. So any questions before we go on to the case study 4, which is a little bit different as far as presentation is concerned? Any questions? Okay. Yeah. Let's go on to case study 4. This is a very interesting case study because this patient presented with a wide variety of presentation. His presentation was evolving because when I started seeing him, he was very acute, which means that his symptoms started maybe a month ago. And then every time I saw him, he presented with, so I've seen symptoms evolve. Like on day 1, he was just presenting with headaches and dizziness. I was seeing him once a week. So in week 2, he was presenting with gut issues. In week 3, he started developing tachycardia type symptoms. So I've seen symptoms evolve, and that is an interesting. I think you should check. Yes, absolutely. Yes, I think we talk about how vestibulocochlear nerve can, if you have a upper cervical dysfunction, C01 dysfunction, C12 dysfunction, it can cause increased inputs in your vestibulocochlear nerve. It can cause increased inputs in your extrapyramidal tract system. And that can cause dizziness type symptoms. We call it cervicogenic dizziness. But you also should check position of the C1, because that's why the lecture is all catered on C1, because more and more, I think these things are missed. Okay. These things are missed. These patients go from provider to provider. They don't have a clue. Most people don't have a clue. I can promise you, once this lecture goes on YouTube, I will get like patients who are suffering from this, because most of these patients self-diagnose themselves, and it takes them years to actually get to a point where they are diagnosed. Okay, which is very sad because they're missed. Okay, so So history of this patient was, he was in an assault where somebody was holding his head, very similar to the self-defense class patient. So patient had this acute head and neck injury, where there was like in kind of a bar brawl kind of a situation where somebody just had a fight with him and just holding his neck. And since then, he's never been the same. A lot of deep, dull pain on the left side. And you can see symptoms like tension headaches, low back pressure, jaw, temple, frontal pressure. So a lot of symptoms like this. Okay. We did the cervical exam and I found C0, C1 MIA dysfunction. And he was very different from all the other patients because you can clearly see a mechanical trauma here. And it's hard to say what the position of the neck when this he went through. So he had something called as he was left side bent and left posteriorly rotated because the symptoms were like right here. Okay. And probably one of the very severe symptoms, his life change. He works in tech and cannot concentrate just because very poor concentration, headaches, insomnia, cannot sleep. And once we started correcting it, headache starts to disappear. Okay. He still has some difficulty with certain things, but I think the body is centralizing. I think I've seen him like 4 times and seeing we going once a week. And very interesting presentation. The key thing here is I keep going back to this. Assess this. Okay. My patient is on its way. I think I'm going to show you how to palpate again. I'm going to show you some of the techniques you can do. You don't have to be an expert to align C1, and that's a good news. Okay. You don't have to be an expert, but you do have to understand what to screen and how to screen. That's very important. Okay. Don't do manipulations. In some situations, I'm going to talk about that. I'm going to talk about treatment. Yeah. You can assess the segmental side glide test. All you're doing is patient is on prone. You're just doing side glides on C0, C1, which I will demonstrate when my patient comes in. You can do AP and PA mobilization. You can check the cervical range. You can do distraction and compression, and you can palpate along the articular pillars, which I'm going to demonstrate. I'm going to demonstrate how. So before even going there, how to evaluate that C1 in its transverse direction, understand how it sits in the body. This is your C1, right? The C1. The only structure that you can palpate is transverse process, right? If right transverse process is inferior, okay. If right transverse process is inferior, what do you call this? Let me write this and let's actually do this small activity. If right TP is inferior, what is your interpretation? What is this movement? Right. If I'm feeling that this is inferior, right side, what do you call this? What is happening at C1? Anybody? I mean, you understand basic mechanics, lateral bending on the right side. Yeah, very simple. Okay. If right transverse process is anterior, what is happening? If right transverse process, this is anterior, this moves forward, what is happening? Anybody? Right TP is anterior. Guys, please don't write on the screen. I mean, that's kind of rude. Okay, don't draw on the screen. Rotation, exactly. So you're having you're getting the rotation on the opposite side. Okay, you're getting the rotation on the opposite side. Okay. Okay. Before you okay. Before you do anything, you have to do a precautionary screening. You will do a Ehler ligament test. transverse ligament test, which I think we spoke about this in the last class, so you can look at the previous lecture. I want to spend time talking about how you can align C1. That's what I'm interested in. Show you a few ideas. There are a wide variety of techniques you can find on internet, but the idea is that you understand that it could be laterally bent, it could be rotated. More often than not, you'll find a combination of things. You will find rotated, side bent, rotated, forward forward translated. That's a common thing because all of us sit in like this, right? All of us have upper back stiffness. We do this work, right? So anterior translation is given. We're going to have anterior translation. Okay. Very rarely you'll find like somebody who's posterior translated. It's rare. So we know for anterior translation, you can work on posture. You can teach them deep neck flexor training, train the muscles here, manipulate the thoracic spine. That's given, right? That's if you attend the lectures, we talk about that stuff in so many details. We give you like 50 different techniques to do cervicothoracic mobilization, thoracic manip. You can do that stuff. This is like adding a layer of complexity to that, right? That is given that you're going to manipulate the thoracic spine. You're going to teach them prone I's, prone T's, and prone Y's, all the upper back exercises. That's foundational stuff. We'll do that. We want to make sure that we train these muscles. We bring this back so that patient is not like this, right? We maybe do like some laser training, gaze stabilization exercises, some VOR training, so that they can train these small muscles, rectus capitis anterior, rectus capitis lateralis. We can train that. Longus colli, we can train that, right? That's given. But we are more concerned about the more important complex stuff. We want to fix this. We want to fix the side bend. We want to fix the rotation. Anterior translation, all of us can fix. I know that most people know how to pop a thoracic spine, especially people who have gone through our course, or do thoracic mobilization. Patient is in prone, you're doing PAs, that's thoracic mobilization, right? Okay. You can do a suboccipital release that will fix the anterior translation too, right? Because if this is sitting and I'm pulling from like here, patient is in supine, I'm bringing it back technically with gravity, right? So anterior translation is easy to fix. Where most of you would struggle is understanding the rotation part and the side bending part, which I think I want to talk about, have a little bit of discussion so that you're looking at it and just understand the kind of subtle variations, and so that you can align this, or you can align this. I don't think it's hard to align this. Very simple. There are wide variety of techniques which you can use for anterior rotation, for side bending. Okay. Yeah. Any questions till now, guys? I think I'm seeing whether my patient is here. I think my patient is here. So I'm going to spend time treating this. I'm going to start with very simple techniques. Okay. And then we'll go from there. Okay. We'll take like a 5-minute break here I need time to set it up so that I can demonstrate this. Okay. So on the other side of C0C, we were targeting C0C1 with the upper cervical distraction. That's correct. But it's not targeting the unilateral stuff. When you're pulling it, if it's anteriorly translated with gravity, you are bringing it back, right? I'll demonstrate the C0C1 distraction too, but we know for the fact that this is a very low skill technique. All of us know that. I want to spend time talking about a little more advanced stuff, talk about how we can easily correct C1 side bending and rotation. I think that's where I think the challenge comes, because I know that most of us, can do suboccipital. Most of us can do chin. Even chin tucks can correct the anterior translation, right? We know that. It's just simple stuff, right? But I think I want to talk about more complex stuff. We want to talk about the side bending and the rotation part, right? Okay. Okay, we're gonna take a 5-minute break. I'm gonna shut the video and I'm gonna do a little setup so that my patient is ready. And I think we're gonna talk. Okay. Thank you. I'm just going to suck it up. Me back, yeah. So, guys, is my patient visible to you? Okay, so this is
Yes, sir, it is visible.
so so this is what you're gonna do. So how to palpate C1 transverse process, find mastoid process, right? Go anterior, inferior, okay? And this is your, you cannot miss it. Yeah, this is your C1 transverse process, okay? If you look at, this is how C1 sits, right? Now, if it is side bend, this is side bending, right? This side transverse process should be inferior, right? In case study 1, 2, and 3, I'm finding a presentation where it is side bent and rotated up. Okay, and that requires a little bit of understanding. So if you see this side bend and rotated forward, most of us are right dominant. So that presentation seems possible. Okay, side bend and rotated forward, and a little bit of interior translation. Side bend, rotated forward, and a little bit of anterior translation. So, yeah, one of you was talking about suboccipital release. Say that if it's just anteriorly translated, sitting here instead of here, right? When I do this, do a suboccipital release, I'm creating a little bit of a space to correct this anterior translation. Okay, we do chin tucks. I think those are very simple and very basic techniques. Okay. But the level of difficulty comes in when you're finding a little bit of lateral bending and a little bit of rotation. And that combination is very much possible, and we see it all the time. Okay. Okay. So lateral bending, case study 1, 2, 3 is lateral bending and rotation. Okay. So we're going to talk about how to address that. Okay. There are muscle energy techniques you can use. There are a wide variety of techniques you can use. Because this is an online lecture, I would not take this information and start manipulating patients, because that's wrong. Okay. I would just do mobilizations. Okay. And just try to stick to that. Okay. I'm going to demonstrate. I did demonstrate suboccipital release. There is another technique you can use for this is for atlanto-occipital distraction. Again, you can use this for anterior translation of C1. It doesn't do anything for side bending or rotation. So it is not doing anything for side bending or rotation. All it is doing is you're correcting the anterior translation, creating a little bit more space between C0, C1. Might help patients who have hypermobility. We were talking about distraction and compression. If somebody has distraction and compression, this is a great technique. But it will do nothing for the side bending and rotation. I keep saying that, but that's important. Okay. I'm going to do a little bit of a setup and I'll demonstrate this, what you're doing. Okay. I think we do teach this technique in our program. I think very, very foundational, very basic technique, but I'll do a little demonstration here. Okay. Yeah. So So my patient is in supine, okay? I'm going to stand on the side, okay, in a staggered stance. I'm going to move the camera a little bit back so you can see my position better. Okay. Okay. So I'm in a staggered stance. Okay. My goal is to catch the occiput with my base of my second metacarpal. Scoot a little bit towards me. And I think you probably would require a high-low bed so that you can adjust according to the height. And you're going to do a little chin strap and you're going to lift it up. You're very wide, so you might scooting this way a little bit. Thank you. You'll do like a ipsilateral side bending, contralateral rotation. Yeah. And just let it go. Okay. Kind of do like something called as a hug touch squeeze. You're holding it here and you're basically gliding it forward very gently. Okay. All you have to do is just hold the patient and do a little bit of a weight shift. Okay. This will correct the anterior translation. If you don't want to do this much work and you're lazy, this works fine as well. Yeah, this works fine as well. Yeah, this does the job. This works fine as well. Yeah. Okay, I can demonstrate from the opposite side and it will be better. I kind of agree with you on that. And yeah. Yeah. So this would actually be, this gives a better view of position. So I'm using my base of my second metacarpal going behind the occiput. Okay. I'm in a stagger stance position. Okay. Patient's neck is in ipsilateral side bending. Okay. Contralateral rotation. Okay. And all I'm doing is a little bit of a weight shift. Okay. Kind of a chin strap position. I'm holding the chin and all I'm doing is this. Very gentle, nothing crazy. Okay. You don't have to be forceful here because it doesn't do anything. All you're doing is gentle. Okay. Low force. Okay. Be specific on what you're mobilizing. Okay. And this is atlanto-occipital distraction. You can do this one. You can use, I think, a towel, which is very similar. I think you can have a towel here and you can do, this is very generalized. All it will do is correct the anterior translation. It will do nothing to side bending. Distraction force is upwards, yes. So I'm holding like this, and this is what I'm doing. Going straight ahead, just weight shifting. I can go back a little bit to show my foot position. So you're doing just this. Yeah, very simple.
Rocking the baby.
Yeah, rocking the baby. Yeah. Okay. I'm not going to show you the adjustment because I think I don't want to teach adjustments online. This is not ipsilateral eye, which I'm going to demonstrate the ipsilateral eye. So for C0, C1, you're just going straight ahead. For C0, C1, you're just going straight ahead. Okay. For C1, 2, this is a technique which corrects your lateral bending. C1. So I'm gonna show this again. So this is how this set, right? Now this is side bend, right? This is how you're gonna correct the side bend. Okay. You're gonna be on the side. You're gonna find the transverse process again. Okay, lift up the head, ipsilateral side bending, contralateral rotation. Okay. Ipsilateral side bending, contralateral rotation. You're on the transverse process. Okay. Or just behind the transverse process. And you're mobilizing towards the ipsilateral eye. Okay. You can look at the arrow. Okay. Your elbow position should be towards the same side of the eye. Okay. In C0, C1, we were this. In C0, C1, 2, or when we are mobilizing C1, lateral bend. That's very important. This technique will correct the lateral bend. Okay. This, like this, I am pushing here, trying to fix this. Okay. Your understanding makes a hell lot of difference. If you're looking, if you're trying to, you want to treat correctly, accurately, understand this. You're trying to push here so that you can fix this. This is a positional fault, and you're doing this to fix this. Okay. But the problem with this, with POTS, and problem with these kind of dysfunction is that you cannot rely just on one technique. One technique will not fix it. You have to combine different techniques, because this thing is moving in 6 planes, right? You cannot just fix in one plane and think that you helped the patient. You did nothing, right? If you just corrected side bend, who's going to correct the rotation? You have to correct the rotation. Okay. So, okay, I'm going to show you the rotated portion. Like there are a couple of techniques which you can use for rotated. I'm going to show you the MET first, which will make more sense. Okay. And this picture might be misleading, but let me show you how you correct the rotation. Say we are treating our case study 1 to 3. We corrected the anterior translation by doing a suboccipital release or cradle the baby technique, go straight. Okay. And then we corrected C1. We corrected C1 lateral flexion with ipsilateral technique, ipsilateral eye technique, where we are going towards the ipsilateral eye. We still have to correct this, right? We still have to correct this because this thing is having fun and it's moving in all planes. So to correct the rotation, this is what you do. Okay. If this is rotated forward, you're gonna pick the head. Okay. Just stay like, get like complete capital flexion where chin is touching, and you can use your body so that the head rests on your trunk. Okay. And what you do is you go and turn to the other side. Okay. Okay. My goal is I want this to rotate posteriorly on the right. That makes sense, right? Because this is rotated forward. Okay. And I'm going to find the barrier, and I'm going to ask the patient to turn towards the right. So can you mind turning to the right now? 1, 2, 3, 4, 5. Hold it. And then find the new barrier. Relax. Okay. And then ask the patient to turn to the right again. Turn to the right. 1, 2, 3, 4, 5. Yeah. Turn more. Turn to the right. 1, 2, 3, 4, 5. And turn to the left. Yeah. And turn to the right again. 1, 2, 3, 4, 5. Okay. This is a technique you're going to use to correct rotation. So the idea is you're going to correct the anterior translation. And you'll find this combination all the time. If I'm finding it, I think you'll find it too. Suboccipital release. You can do a lateral bend correction via ipsilateral technique. Okay, and then you'll correct. This might create some dizziness for sure. Your patient has resting dizziness. Your patient has resting dizziness. So I mean, I don't think you're going to create additional dizziness. And their dizziness becomes worse when they stand up. Right? That's POTS. When they're here, they already have dizziness. You can't do much about it. And you're not manipulating, you're just mobilizing. Right? We spoke that if you have 5 Ds and 3 Ns, you're not going to do a manipulation. You're just doing mobilization, grade 1, grade 2, good enough to correct it. Okay. Yep. So this is, I don't want to lose my chain of thought. So anterior translation, you corrected the lateral bending, and then you corrected the rotation via MET. There is another way to correct the rotation, which I'll demonstrate, and that's a little high skill technique, which I'm going to actually demonstrate, because you want to correct at least 3 or 4 components out of 6. If they have everything present, then I think God bless you. Because if they have lateral translation, technically you are also correcting lateral translation when you're doing the ipsilateral eye technique. Okay. But the game is that you understand dry needling can be applied, of course. You can add dry needling to it. If you feel that dry needling for release, yeah, absolutely. Do it. The idea is that just don't rely on one technique and think that this stuff moves in like 3 or 6 planes, right? And combine all the techniques, okay? And sometimes it's going to be a little bit of hit and trial before you master which one works, but at least you're helping them. You're at least understanding that this just not goes forward and back. It also side bend, it also rotates, right? Okay. If you've gone through the program, I think we talk about different techniques, different things, but this is like this class is like a layer of complexity ahead of what we have already know, because this thing is just having fun, just moving in all directions and causing havoc in patients' life, right? Okay, I'm going to show you a couple of more techniques, and those techniques are in sitting. So I'm going to get my patient in sitting position. Just give me 1 to set it up, 1 minute to set it up, and then I think we'll. Okay. Do you mind coming to the chair? I think it's very high. लोगों को समझ आ रही है तो फिर क्या but some of them are very smart. Some of them are propaganda and they practice for a long time. So hopefully they'll understand it. So this is what I'm going to do so that we don't be like. Okay. Okay, guys. So I think I'm going to demonstrate this, and I think this is important for you to understand. So this is your C1. Consider case study. Consider case study 4, where this was rotated posteriorly, right? Case study 4, this was rotated. Okay. You can correct posterior interior rotation by these 2 techniques, which I'm going to demonstrate. Okay. You still have to correct the side bend because I think it always will be there. So this stuff is rotated posteriorly. If you think MET is not helping you, there is a way to correct this. Okay. What you're going to do is you're going to stand on the opposite side. So if I'm correcting the left side, I'm going to stand on the right side. Okay. And if you want to be nice to your patient, you can use a little bit of towel. You can keep it here and ask the patient to rest on the towel. Okay. You're going to use something called as a turban grip. You're going to keep one hand behind the transverse process of C1. Okay. And you're going to do a little bit of a ipsilateral side bending. Okay. And a little bit of a contralateral rotation. Okay. And you're behind the transverse process. Okay. Don't manipulate, because this is not a class to teach you manipulations. Just find the transverse process and keep one hand on the occiput, and all you're doing is a gentle anterior glide of C1. Okay, you can take a little bit of a slack. Okay, and if it's posteriorly rotated, you're doing a little bit of a gentle glide. Okay, this forearm is resting on the occiput, helping me create a little bit of distraction. If you're not finding the barrier, you can do a little bit of side bending, and all you're doing is just a little bit of anterior glide. Okay, so rotate it posteriorly, you want to move it anteriorly, and that will correct the rotation, posterior rotation. Okay, not a hard technique, just understand the mechanics, try to find the barrier. It's also for LPS, but I think I'm trying to show you C1. You can use it for LPS too, you're correct. I think Dr. Tarmay has gone through the program, so he understands but the idea is the techniques stay the same. You just have your understanding evolves, right? When and for what you can use it for, right? So, okay. This is what you're doing. You're moving it back. Okay, this is for posterior rotation because you're trying to move the C1 forward, right? There is a technique for anterior rotation. Say if I'm trying to correct the anterior rotation, the positioning stays the same. What changes it is your hand grip. Okay, patient still rests on your chest. Okay, now you're gonna go anterior to the transverse process. Okay, and the hand stays on the occiput. Now what you're doing is you're creating side bending rotation, and now you're moving that C1. Manipulating hand is your C1. This is the stabilizing hand, and you're moving the C1. You're moving the C1 posteriorly. Okay. Not a hard technique. All you have to do is find the C1 transverse process. In the previous technique, you have to be posterior to it so that you can move it anteriorly. In this, you can be anterior to it so that you can move it posteriorly. So you're correcting the anterior rotation. Okay. If you're not happy with these techniques, you can just do the MET. Okay, that is perfectly fine. Okay. Do you mind laying on your back? Yeah. Please close this. Glare coming. So any questions, guys? Anything you want me to repeat again? So the idea is we appreciate that C1 moves in 3 planes or 6 planes, but you can have combinations. More common combinations could be side bending and rotation, side glide plus rotation glide plus anterior translation. Anterior translation you will find all the time. So let's go back to the previous slide, previous slides, and go back to the first slide, biomechanics, understanding. Okay. So flexion and extension and anterior glide will be there because of the posture, right? Okay. For this, I want to work on the posture, work on all the regular stuff we work on, chin tucks. You can work on suboccipital release. Okay. Lateral bending will correct by doing the technique I demonstrated, ipsilateral eye technique. Yeah. The point is that you cannot correct C1 without pushing on C1. That's just how it is. If it's lateral bend, you have to push on the C1 transverse process towards the ipsilateral eye. Do the selective distraction of C1. Yes. Ipsilateral eye. We talk about these techniques in more detail in the program. So if you have any questions regarding the program, you can reach out. Yeah. And then during to correct rotation, I think I demonstrated either you use a MET or you use a technique in sitting techniques, which I demonstrated, where you either push on the transverse process from front, from interior to posterior or posterior to interior, and your other hand stays on the occiput, and you basically glide that. Okay. If you combine this, you're addressing C1 in all different planes. Okay. And you can add like suboccipital release to it, because if your C1 is getting compressed between C2 and occiput, you're at least releasing it. Okay. Okay. So when you're in the clinic and you're seeing somebody who has orthostatic hypotension or tachycardia kind of symptoms, and you think that it's coming from C1, make sure you palpate the transverse process and at least go through these techniques. See if you can create a difference, followed by your regular rehab. You do improving posture, upper back strength, upper back flexibility. You can add a thoracic manip to it. A lot of times you will see a pelvis dysfunction secondary, like my case study 2. She had a complex pelvis presentation, a sacral flexion on one side, a sacral extension on one side. It doesn't matter what I do. If I don't treat that, this is just going to be temporary. Okay. So make sure that you're treating the pelvis and addressing complex SI problems with it, because I think that is throwing off this. So make sure you treat both. Okay. So upper back stability and control, and treat secondary dysfunctions. In pelvis and thoracic spine. So that's a great question, actually. If you have a C1 dysfunction, you can have a mid-cervical dysfunction that can give you symptoms down the arm. Or maybe because of C1 dysfunction, you're getting a brainstem compression. That can give you symptoms anywhere. Brainstem compression can give you symptoms in the arm, in the legs, numbness in the arms and legs, right? You're getting a cord compression. We did speak about brainstem compression in the last class, and that explains the numbness and tingling. One of the case studies, I think case study 3, we were talking about numbness and tingling down the leg and down the arm. That explains it. Okay, so you're getting something called as brainstem irritation. Okay. Yeah. Any questions, guys? I know this is a very heavy lecture, but I think I've tried simplifying it. This will be on YouTube. You can go and watch it again. And currently we are doing a cohort 4. I think if you're interested in going through the program, learning more complex stuff, understanding how our body moves, you can reach out, and you can reach out to Dr. Dhrumi. She handles it. And yeah, I mean, if you have any questions regarding the program or regarding this diagnosis, I think you can reach out to us as well. And this is a very, very complex class. I think I would go back and look at the slides again, and I would listen to the lecture again. And I think maybe we'll do a follow-up on this, maybe a part 3 on this. And I am in touch with one of the chiropractic physicians who I work closely with. I might ask her to take a part 3 on this, because she might have a different take from a chiropractic viewpoint, what she thinks about C1. She primarily treats C1, so she has more understanding from the chiropractic viewpoint. But we tried covering it, how we can address it in all planes, and how we can assess it in all planes. We did spend a lot of time testing C1 in last. C1 and C2 can have both actually, open or closed. Open is more common, but it can have both open or closed dysfunction. Okay. The okay. But C1, C2, I think how we diagnose it is if you have pain and restriction on the same side, we call it a closed dysfunction. If you have pain and restriction on the pain on the right side, restriction on the opposite side, that brings on symptoms, that's open dysfunction, right? So, but the key thing here is if you look at it, I mean, if you correct C1, you're addressing both C0, C1 and C1, C2. So it doesn't matter whether you have an open dysfunction or closed dysfunction. If you understand the mechanics of C1 and you align it, you're addressing both. And I always love to treat C2-3. There's a technique for C2-3 which I can demonstrate because C2-3 is a segment which usually is in dysfunction from the simple reason that it's a transitional zone. So I'm actually going to show you C2, C3 technique. I think it's on one of the slides. It's not related to the lecture, but you can have a secondary dysfunction anywhere. You can have a secondary dysfunction in C2, C3, or you can have a secondary dysfunction in C5, C6, giving you arm symptoms, C6, C7, C8, depending on where you're feeling the symptoms. We see that all the time, right? You can have secondary dysfunctions. C5, C6, C6, C7 is median and ulnar getting compressed is very, very common. Maybe it's getting compressed on first rib, maybe it is getting compressed in thoracic outlet, right? But this could be the precursor. C1 could be the precursor, and then you have secondary ramifications of other nerve related problems or peripheral nerve entrapment. Okay, I'm going to actually demonstrate C2-3, and it's very similar to C1-2 or C1 lateral bending correction I showed you. And C2-3 is very simple. So I'll demonstrate that. Okay, very quickly, and then I think we'll probably stop for the day. This is C2-3 technique. The positioning stays the same. It's not any different from what okay. So patient is still in supine. Okay, you come on the side, and rather than grabbing onto C1 transverse process or C1 articular pillar, you grab onto C2 articular pillar. The good thing about C2 is the spinous process is massive. If you start palpating occiput and then go down, the first spinous process you will feel would be C2. It's huge. If I can show you on the if you look at this spine model, okay, this is occiput. The first thing you're going to hit is C2, okay, and once you find C2, you just come a little bit medial to it, and you glide it. Very, very simple technique. The only minor difference here is you're palpating towards the contralateral eye, not the ipsilateral eye. Scoop this way, please. And, okay. And okay. You're going to keep the base of the metacarpal, index finger, ipsilateral side bending, contralateral rotation, and you're finding C2. C2 is very easy to find the spinous process. Okay. And your elbow position is towards the contralateral eye. If you look at the slide, okay, very easy. If you're finding tension in the C2 area, you can do that too. Combine that with it. Okay. But just to sum it up, if you're addressing C1, make sure that you address in all planes. That's the most important takeaway from this lecture. 6 degrees of freedom, you address in all planes. You can add dry needling to it, treat the secondary dysfunctions, look at autonomic system, nervous system, look at vagal related symptoms, look at brainstem related symptoms, look at GI related symptoms. Okay. And look at this cluster. If you're finding this cluster, you're definitely treating something with C1 misalignment. Sometimes patient would tell you that they feel off balanced. They feel that they are disoriented. They feel that their body is not centered. So those are the kind of comments you will hear from patients who are presenting with POTS, because your body is just in massive dysfunction because of C1. Okay. and they have difficulty concentrating, they feel brain fog, they feel confused, and their overall quality of life is very, very poor. I have a patient who can't drive. She's like 30 something, 33 years old, one of the case studies. Yeah. Sounds similar to vestibular dysfunction, but we know that vestibular dysfunction corrects itself, right? We know that if somebody has a positional vertigo, they don't have GI symptoms, right? They don't have difficulty. And we know that positional vertigo, if you don't do anything, in a week, it resolves itself, right? It comes in like kind of a flare-ups. You go from 0 to 100 in a week, and then you're fine, right? So, but POTS is, if you have POTS, it's going to control your life. You're not going to get better spontaneously like you get better in vestibular dysfunction. Vestibular dysfunction is actually self-limiting. If patient has positional vertigo, BPPV, you don't do anything, in a week or two, it resolves itself, right? And if they do Epley's maneuver, it resolves in 5 minutes. Most of them, right? So I'm talking about majority of the patients, not all, of course. Yes, need to differentiate from each other, but I mean, here you're getting everything. You're getting GI symptoms, you're getting tachycardias, which are not present in all those, right? Here you're getting everything. You're getting wide variety of plethora of symptoms, like very, very complex presentation, right? So vestibular dysfunction is hard. I mean, it's a different field, and I think it requires a different eye to look at it. But I don't think it's as complex or as challenging as this. This is very challenging, and I can promise you that it gets missed all the time. It affects all the 4 patients I treat. They are very depressed. Or the 4 case studies I've mentioned here are very depressed, just because the severity is just out of ordinary. That's why I think we wanted to do a lecture on this. Okay. Hopefully it goes on YouTube and somebody looks at it, and if they're struggling to find a diagnosis, they'll be able to find their diagnosis. Because that's how patients are finding their diagnosis. They're not getting diagnosed by physicians. It gets missed for years. And then they basically, because some of the symptoms are not explainable, right? Well, there's no test for poor concentration and body fatigue and, I mean, allergy to all foods, right? So that's why it gets missed. Okay, I think we'll stop here. And we're planning to teach a class in India in December, and we're running cohort 4. If you're interested, you can reach out to Dr. Dhrumi. And this will be on YouTube if you want to look at it again. And I want to thank my patient, Dr. Shahid, who helped me with the class, and he was very patient. And and I think we'll see you in another lecture. Okay. Thank you, guys.
And I should follow your YouTube channel. I can learn stuff too.
Yeah, I mean, I think this is a very, I think, complex area, which I'm seeing.
I can